podcast recording of the Rofi Collective podcast. My name is Larissa Assam, and I will be your host for tonight. So, before we get started, I'll just briefly introduce myself and share a brief disclaimer, and then without further ado, we'll get right to it. Okay. Today's topic is one which I believe is absolutely necessary. I think this conversation needs to be had, and it's rather unfortunate that we actually have to talk about this, but I think it's necessary. So, my name is Larissa Sam. As I mentioned, I am a physician. I am a voice for women's health diplomacy. I am also a published author by the grace of God, and I own a platform called Rofi, which is helping prevent complications in pregnancy and postpartum amongst women. Amongst that, I do a couple of other things in the realm of entrepreneurship. But for today, the key emphasis is, by God's grace, I believe God has given me a voice for international health affairs, global health affairs. And so when different things happen in different parts of the world, some things, if they're within my area of expertise and know-how, I will discuss them, but others maybe not. But this is a topic that I think is very important that we talk about on multiple levels. And so without further ado, let's get into this conversation. Today, we are going to be talking about Chimamanda Adichie's loss. She lost her son, unfortunately. And we are also going to be talking about the Nigerian healthcare system. Okay. I believe that this is a wake-up call beyond an individual incident. This is actually a wake-up call for a health system in regards to infant health and also in regards to patient safety. First and foremost, I've met Chimamanda before, and she was absolutely lovely. She's such an inspiration. I've read so many of her books, and we had actually even had a conversation a while back. I'm going to look for the picture we had taken together years ago when I was at Hopkins. She had come to do a talk, a presentation there, and I was literally thrilled because she's literally one of my favorite African writers. And so in January of 2026, so last month, she and her family were in Nigeria. They were spending some time there. And her son, Nkanu, may his soul rest in peace, was 21 months old. And they took him to seek medical care in Lagos. Based on what I understand from the story, they were due to actually travel, I believe, the next day or about 2 days later, but they wanted to just make sure he wasn't looking too well and said, let's just get him checked out at the hospital before we go. One thing led to the next, and essentially the family believes that there was medical negligence that was done during routine procedures. From what I understand, I believe he had to maybe have like a spinal tap. I could be wrong. And during that procedure, which is not really a routine procedure, to be honest, he was sedated with propofol, which is a medication that helps put one to sleep. He was not monitored appropriately, and these events led to his death. All right. So this is what has opened up this discussion about the Nigerian healthcare system. But I think it's a bigger discussion. That is one country. Depending on the lens you're looking at, you can look at it as Nigeria, you can look at it as sub-Saharan Africa, you can look at it as the global south. It depends on your purview, your perspective. But ultimately, I think it begets the question to discuss infantile health and patient safety on multiple levels. It's also important to note that these kinds of situations can actually happen anywhere and everywhere in the world. The numbers may not be as high, but these things actually do happen. It was not due to sedation, but I remember, in medicine, there are key moments that you'll go through and they kind of stay with you for the remainder of your career. Not that they are causing trauma, but they're key lessons, key milestones, key time points. And I distinctly remember when I was in my third year of medical school, I was on my emergency medicine rotation and I had just gotten to the emergency room. I believe my shift was starting at 4 p.m. So that is how vivid the memory still is to me. I still remember the exact time that I got to the emergency room. As soon as I got there and I started my shift, the doctors, I got told to go into a trauma room because there was a 3-week-old who was coming. And essentially, as a team, we were going to try and resuscitate the baby. I went into the room with the rest of the team, and, we started to do the needful to try and resuscitate the baby. After over 20 minutes of trying, I mean, the father was standing in the corner crying, just very confused, because what had happened was he had literally just put the baby down to lay on his back, gone into the next room to put down plates that he had literally just used. By the time he came back, it seemed like the baby had rolled over onto their stomach and the baby had turned blue. So there is a condition, I don't know if you've ever heard of it, called sudden infant death syndrome. And unfortunately, this is what had happened to that baby. No explanation. Some way, somehow, the airway basically got enclosed and the baby could not breathe. And so despite multiple resuscitation attempts, we were not able to bring that baby back to life. And that was medical school. That was my third year. I still remember. Again, I remember even the time point. But I share that to say that's how distinctive things stick with you as a doctor. I dare to believe no one walks into a room saying, I don't even care, whatever, whatever. I can't speak for others, but for me, at least, that's not the mindset, right? And I dare to believe that that's how other people feel. So when you hear of stories wherein anyone dies, talk less of a child dying, a 21-month-old dying, it's heartbreaking. Wherever in the world you find yourself, it's extremely heartbreaking. And then it begets the question, what happened? What led to this? And that's what I want to focus on today as we have this conversation, because I believe this is a bigger conversation. It's unfortunate because what it shows is that even for such a public figure, so to speak, no one is really exempt, so to speak. So it's important that we learn, we know these things, and we have these conversations, on all levels: private institutions, public institutions, governmental institutions, the WHO, the UN. On every single level, we are discussing these things because they're not new. So let's talk about some relevant health facts and the data behind what we're seeing. So in Nigeria, the under age 5 mortality rate is about 105 deaths per 1,000 live births. At face value, it may not sound like a lot, but that's actually quite high. It's considered far above the global average, and it's a combination of multiple health inequities, multiple. All right. Infant mortality, which is deaths happening before age 1, it's around 60 per 1,000 live births. Again, this is high, and this is data according to UNICEF. Now, when we get into childhood, globally in 2023, about 4.8 million children under age 5 died, and there was an average of about 13,000 children dying per day. But this is believed that this is actually underscoring the fact that one, a lot of these deaths are preventable. Two, this is still a global problem. And that was 2023, but I dare to say in 2026, this is still an issue. So malnutrition is actually known to be the leading cause of death in children in Nigeria. It contributes to roughly 45% of under 5 mortality, under 5 deaths. So if you think about it, in an area wherein food is grown, food is imported from neighboring countries. I know growing up in Cameroon, we literally would export so much food to Nigeria. Still, with that, roughly 45%, so almost 1 in 2 deaths happening under age 5 are due to malnutrition. That is a huge problem. Huge problem. And then we have to talk about the system, the healthcare system, the capacity. It's a known thing. Nigeria, similar to other sub Saharan African countries, the doctor to population ratio is critically low. Not only is it low, but it is critically low. And there are so many reasons for this. There's a massive brain drain, meaning those who are competent, who are trained and able to provide care actually would prefer to leave the country. And there's so many reasons for that: how they're treated, how they're paid, the frustrations in trying to provide care to your patients. There's so many reasons. And then the life expectancy in Nigeria is also worth discussing. It's currently about 54 years for both men and for women. And this is also below the global average at the moment, and even African benchmarks. Okay. So, what are some things that we need to discuss or kind of take away from this tragedy that happened? The reality is that it unveils a deeper public health issue or a deeper public health reality that has been present for quite some time. So, safe care, it's one thing to have access to care. You can have a hospital, you can have a clinic, but the question is it safe? In this case, based on the report from the family, the concern was that there was not sufficient continuous monitoring. Whenever someone is going to have surgery of any kind, sedation of any kind, it is imperative that they're continuously monitored. It's actually quite interesting because Michael Jackson, if you remember the story with him, it's actually the same medication, propofol, that was given to him, in his case for pain, to help sedate him somewhat. And he also had a degree of an overdose on that. And so it can happen to adults, it can happen to children. I've seen this happen, not lead to death, but happen several times clinically. And if it's caught early, there are things that you can do to kind of reverse it. But unfortunately, if it ends up being too late, it can cause what we call respiratory depression, meaning a person is not able to breathe as often as they need to per minute. The lungs, the diaphragm is a muscle at the base of the lungs, and it's supposed to help you breathe. And so what happens is a medication like propofol, one of the things it does is it kind of relaxes all the muscles. And so the diaphragm, which we need to breathe, will also relax. And unfortunately, if you're not breathing, then you can't live, right? You need to breathe, you need blood flowing, and it's all necessary. So someone asked the question, they said, should it be used? Is it safe? I think it can be used. I think it can be used, but you need close monitoring. And that's really the bigger question. It's not necessarily that the medication is dangerous, but the dosing matters, the response to the patient matters. I remember once when I was in residency, we had a patient who was quite sick. She had cancer and it was terminal. And so we were taking care of her in the hospital, but essentially she was so uncomfortable that she was given pain medication. She was given opioids. And what happened was, because of her weight, her body mass, we gave her a dose that was not abnormal at all. The team gave her a dose, I should say, that was not abnormal. But what ended up happening was, in her case, it was too much for her. Sometimes you only ever know based on the patient's clinical response. So I can give someone, I'm just using this as an example, 2 milligrams. Someone else, I can give the same 2 milligrams, but 2 milligrams in person A and 2 milligrams in person B are two completely different things. This is why continuous monitoring is absolutely necessary. And it seems like that was the missing piece. Now, in Michael Jackson's case, I don't fully know what happened. I don't know all the details of the case. And that's the reality of talking about cases publicly. You know, I say this with a lot of respect to my colleagues because you don't know the details of the case. If you were not the one administering the care, the one receiving the care, there's always the court of public opinion, right? And in today's day and age, we see that so much. So I think it's very important to also acknowledge that these kinds of conversations, which I have in particular, I have to raise awareness to know, hey, these are things you should know about. If you live in these parts of the world, if you travel, and, as we've discussed, I'm discussing cases in America, I'm discussing cases in Nigeria. So overall, these are just things you should be aware of. But ultimately, the specifics of the case will always vary. Always. That's literally medicine. It is not a perfect science. And we are constantly learning, constantly evolving, constantly iterating. I remember once a mentor told me the day you feel like you know everything in medicine is the exact day you should quit, because you now become dangerous. And so, to anyone who feels like, if you're a medical student or a resident or even an attending and you don't know it all, it's okay. You're meant to do research. I find myself reading research articles just about every single day because it's necessary. And in fact, that I believe that's one of the most important things that I gained training at an academic institution like Georgetown. You learned how to constantly read research and be comfortable with it. You learned that if you didn't know the answer, you went to look it up. You asked questions. And I think that's what makes for a good scientist. That's what makes you a good researcher. So you just want to make a habit out of that. If you don't know, go to your doctor. As a patient, if I tell my patients all the time, if I don't know the answer, I'll do my best to look it up. If I can't look it up, thank God they're specialists. You phone a friend. Hi, can you please help me sort out X, Y, and Z situation? But the medical field, especially in today's day and age, we have so much information, which is a blessing, but it's quite unrealistic for anyone to know every single thing. But when you learn how to be a good researcher, then you learn how to be a good doctor. Okay. So the first thing is we need to really talk more about safe healthcare. Again, access is one thing, but safety is another piece. This is also the reason why a lot of women tend to have complications in pregnancy and also after pregnancy. Some women need to be monitored more frequently than a month. It just depends on the risk factors. It really depends. And that's why I love the work we're doing at Rofi, because the Rofi Maternal Index, it helps governments, it helps public health institutions, it helps individuals even to assess what are the potential risk factors for this individual patient or for this group of people, this country, this city, etc., that need to be taken into consideration. Now, based on that, let's create an evidence-based personalized protocol to help make sure that we try our best, right? We try our best to mitigate any and all potential complications. So this death unfortunately unveiled the fact that there were actually lapses in care, most likely, and there's a need for better safeguarding in pediatric care. This also shows us that no one is immune. I've referenced Michael Jackson, I've mentioned Chimamanda. This goes to show that these are preventable outcomes. But just because you're of a certain socioeconomic class, it doesn't necessarily take that away. Wealth or prominence alone may not protect against systemic failures in healthcare. All right. And then lastly, there are also disparities. There's a high under five mortality, and there are gaps in emergency care and critical care. They don't necessarily isolate incidents, but these are persistent issues, persistent challenges that come from infrastructure to workforce distribution. So the point of that is basically telling you that, yes, I mentioned a statistic earlier about 45% infant mortality, under five mortality rate, in Nigeria, but there's so many contributing factors to that. So what portion is due to emergency care? What portion is due to the fact that there weren't enough doctors? What portion was due to the lack of medication, for example? That differentiation is not that clear based on the research which we have as of today. And so, what are the things that we can do as individuals, as systems, as government? What can we do? First thing, we can strengthen clinical policies and patient safety. I don't know what the policy in the specific hospital is, but it's possible to have standardized monitoring and sedation policies which are present across all facilities, and these will be implemented at the governmental level. So they will be applicable to private hospitals, applicable to public hospitals. Now, it's one thing to have a policy, and after growing up in a country like Cameroon, I very much understand that. I understand the global health landscape and world. It's one thing to have a policy on paper, and it's another thing to put it into effect. So we need both. We need them on paper, but we also need them to actually be enforced. If it's possible to have electronic monitoring, that would be great as well. That's what's used in America, but we have to talk about real life emergency situations and real life practical applications, like the fact that there may not be electricity. What do you do if you're solely reliant on that? These are the practical considerations, and this is why it can never be a one size fits all rule when it comes to making such recommendations. It's very location dependent. Additionally, having emergency and critical care capacity. I remember when I was doing my master's at Hopkins, my master's of public health, I remember doing a capacity assessment, a surgical capacity assessment across some of the major hospitals in Cameroon. It's necessary to assess how are we doing based on the standards. Now, you can use different benchmarks, the WHO, country standards, what have you, but you can identify gaps and then figure out where training is necessary, where certification is necessary. For example, in pediatric critical care, in trauma, in emergency response. And if there's a limitation, how can these things be improved? Also, capacity now has to deal with equipment. Are there enough monitors? Are there ventilators? Let's even talk about the workforce. Brain drain. This has been a conversation that has been happening forever. Frankly, since I was probably about 5 years old in Cameroon, we were talking about brain drain. And unfortunately, it is still happening today. Incentives to retain. So we always talk about the how can we retain more nurses, more doctors in countries like Nigeria. But we have to move from conversation to actually seeing outcomes and figuring out why there has not been tangible change in all of this time. Better reporting will also be necessary, better transparency, accountability, and also even having better patient rights. It really depends on the person, on the case. I believe there's some litigation that is in the works currently. But again, I can say this as a practicing clinician. I see it on both sides. I understand the family dynamic because I've dealt with that myself on a personal level, but I also understand the clinician perspective as well. So it begets for a complex discussion. What do you think actually? I'm curious to know. Let me know what your thoughts are. What do you think about this story, about this case? Let me know in the comments. And lastly, in order to make sure that there is alignment with the recommendations which are made on an international level or even a country level, there's also a degree of investment that needs to happen. So this is very personal. This is very heartbreaking, but it opens the door to a very important conversation. Health systems literally across the world need to make sure that the most vulnerable populations, children being one of them, are protected with all the issues that are at play. Sometimes I find that child health, infantile health, certainly maternal health, can definitely be put to the side somewhat. And so every policy, every change, every clinical decision, I think it's really, really important. And so I hope you gained a thing or two or three from our conversation today. And I think this is very important. If you are listening to this, Chimamanda, my heart goes out to you truly. This is not easy. We can talk about all the data and the science and all of that, but there's nothing like talking about someone's literal child. And for your husband, even being a physician as well, I think that even hits on a deeper level. And so, please, if you ever come across this video, accept my heartfelt condolences. And for all who are listening, this conversation is really meant for educational purposes and for awareness. This is not formal medical advice, but I hope that you gained something new, gained a new perspective, you learned something new about healthcare systems, about infantile health, child health. And I trust that as we continue to work together, we will increase awareness, and we trust that the world will be a better place one day at a time. Thank you so much for tuning in to today's episode. Have a good evening.